Good afternoon, everybody. Thank you so much, NASL, the organizing team, and Professor Ajay Duseja for having me over here. So today's topic is limitations of LIRADS in HCC. I'm an interventional radiologist, and I suppose you all know that one of the limitations of interventional radiologists is talking about a diagnostic topic. Having said that, I'll take you through what LIRADS is for those of you who haven't been using LIRADS, and with some limitations towards the end of the discussion. Before that, can I have a show of hands for people who actually do your own reporting and don't look at a radiologist's report? Okay, very good. Okay, all right. So in that case, the limitations of LIRADS probably doesn't apply as well. I think this is only for those who actually look at a radiologist's report and then think, oh my God, this is LIRADS 4 or LIRADS 5, and then you don't look at your own report. That's when it applies. So what is LIRADS? As you all know, it came after BIRADS. This was introduced in 2018. It is a liver imaging radiology reporting and data system is the name of, is the expansion of LIRADS. And BIRADS, probably you all are aware, it is used for breast imaging. So for liver imaging, we came up with LIRAD. This is just to standardize the terminology so that the communication is much better, so that the interpretation is better amongst the radiologists and the non-radiology colleagues. So where do we use LIRADS? We use it for ultrasound surveillance. We also use it for contrast-enhanced ultrasound diagnostic algorithm. We have an algorithm for CT and MRI. And we also have an algorithm for treatment response. So these are all the various places where LIRADS can be used. It is not just for reporting CT and MRI, but it can also be used for ultrasound surveillance. And for people who are using contrast-enhanced ultrasound, we can use LIRADS there as well. And again, as a treatment response. Basically, just to simplify, there are only 5 things that we need to remember from LR1 to LR5. So what is LR1? LR1 is definitely benign lesion. We wouldn't probably, this is for hemangioma, cysts, etc. LR2 is probable benign lesion, wherein we are not really sure. LR3 is sitting on the fence. We probably will be saying clinical correlation is required, and that is an intermediate probability. And LR4 and 5 are probable HCCs and definitive HCCs. So LRM, again, is a separate category. So when you see LRM, what is LRM? LRM is probably, you would have seen lesions which look malignant, but you really can't pinpoint and say this is HCC. Basically, they are atypical HCCs. They can be HCCs, they might not be HCC, something like a mixed lesion, like a mixed HCC plus cholangio. So if you see a report which has got LRM, that could signify this could be a HCC, may not be a HCC, so we may have to do biopsy in those lesions if it's an LRM. So that is again an MDT discussion that you need to go in for if you see LRM. So that's what it is for the actual LIRADS. And if you see the treatment response algorithm, you have LRTR non-viable, so basically nothing is seen. You do an ablation, you do radiotherapy, you do SBRT, or you do TARE. So what is seen if it is non-viable? You don't see any tumor enhancing, it is LRTR. So if you see, actually this is more confusing than expanding in the report. So if someone says LRTR, you might be wondering what this is all about. So this LRTR is a non-viable tumor. LRTR equivocal is again something which has not progressed or something which has reduced in size is LRTR. And LRTR viable is if you see a definite viable tumor, you see some nodular enhancement, then you call it LRTR viable. So when to apply LIRADS? You apply pretty much for cirrhotic patients, current or prior HCC, chronic hepatitis B infection. These are the patients, especially for adult patients. So the limitations, I suppose, is you cannot apply LIRADS for pediatric patients. If somebody has got a tyrosinemia, a 5-year-old with tyrosinemia, but with HCC, if you have an enhancing tumor, you don't apply LIRADS. So you will never see LIRADS category in a pediatric report. So you do not apply this for a child who's less than 18 years old with cirrhosis due to congenital hepatic fibrosis, because of the vascular disorders, if you have cirrhosis like a HHT, even for diffuse nodular regenerative hyperplasia, for Budd-Chiari, these are the conditions wherein you should not be seeing LIRADS mentioning anywhere in the report. And again, it's applied for contrast-enhanced CTs and MRI as well. So for path-proven malignancies, again, we need not apply LIRADS. So for just the basic, we all know what is, before we get into the details. So first one is a non-contrast image wherein you're seeing, it's not enhancing. The next one is an arterial phase image wherein you see a complete enhancement. And again, you see washing off towards a delayed phase. So basically arterial phase enhancement, arterial phase hyper enhancement, and a delayed phase washout is what we call as HCC. But these could be HCCs, but these are not categorized under LIRADS. For example, the first one on the left side is a congenital massive fibrosis or congenital hepatic fibrosis patient with a hyper-enhancing nodule, and we do not apply LIRADS there. This could be benign, so technically speaking, this would be LIRADS 1. And then if you see the second one, this is a nodular regenerative hyperplasia. You see multiple enhancing nodules, and that doesn't fall under the category of HCC, not a cirrhotic patient, so you may not really apply LIRADS there. And again, there is a limitation there. And the third one, the bottom one, is a Budd-Chiari syndrome with multiple nodules that you see in a Budd-Chiari. Again, you don't apply there as well. So this is a diagnostic algorithm, CT, MRI, LIRADS diagnostic algorithm. All that you need to focus is the last two boxes. Any lesion which is about 10 mm, so 10 to 19 mm or more than 20 mm. What is LIRADS 5 is these last four boxes that we need to understand. Anybody with a nodule which is more than 10 mm but with a non-peripheral washout with a threshold growth. What is a threshold growth? More than 50% increase in less than 6 months is a threshold growth. An enhancing capsule that you see in the delayed phase. These are all the ancillary features, or actually these are the major additional features, I would say, which account for LR5 category of LIRADS. So absence of these will automatically push it into LR3, which is sitting on the fence category, wherein you are like intermediate and we really don't know what it is. So that is a little bit of the background about LIRADS. And now that it is clear, we'll just move on. There are two things in LIRADS. We have got LR4 and LRTIV. Normally you would see reports wherein we say there is a vascular invasion, we say there is a little bit of a portal vein thrombus, malignant thrombus demonstrated in the portal vein, etc., in the description of the report. But if you see a radiologist mentioning LRTIV, this is tumor in vein. The last one, LRTIV, is the LR tumor in the vein. A tumor in the vein does not necessarily mean it is HCC, because you can have tumor in the vein from other diseases as well, from other tumors as well. So LRTIV is a new category wherein you do not include it as LR5. It is quite distinct from LR5. Same with LR4. LR4 is again probable malignant. LRM and LRTIV, they are pretty much look like HCCs, but we do not label them as HCCs. So this is what it is for. And what do you do? Obviously, if it is LRTIV, LRM, if you're unsure of something which is LR4, you end up biopsying that. So unless it is LR5, we do not need to do the biopsy for that particular patient. So these are all some of the terminologies. And in terms of the report, you will always use a term called as observations in LIRADS. We use the term observation. So any of these things is an observation. You can see a nodule, anything less than 20 mm, a mass, anything more than 2 centimeters. You can see a treated lesion. So these are the lesions. And you can also have pseudo lesions. It's very important to understand about pseudo lesions, because LIRADS sometimes can give a false positive result if you just look at the pseudo lesion, which could be an artifact or a vascular pseudo lesion or a hypertrophic pseudomass. All these. I'll just skip this slide just for the sake of time. So do we see HCCs where there is no true arterial phase hyperenhancement? Yes, we do. And that is where you cannot really, that is one of the limitations of LIRADS. What do you do if you have a lesion which is early HCC but doesn't have an arterial phase hyperenhancement? We cannot apply LIRADS there, because the LIRADS might call it as 1 or 2. Actually, it is 5, LR5. Very steatotic HCC. If you have a lot of fat in the HCC, again, they are without true hyperenhancement. Poorly differentiated HCCs with infiltrative appearances may not enhance very well. And you also have got some overtly malignant, like progressive, some expansile HCCs as well. So absence of arterial phase hyperenhancement does not exclude HCC. So how can we apply LIRADS in this particular category? Again, the washout has got the same thing, same features. If you just have a peripheral, more pronounced peripheral washout, it comes under LRM. You would have seen some CTs wherein you just don't see the complete washout, but you just see the periphery of the tumor showing some washout. But we still call it HCC. But then according to LIRADS, it falls under LRM because there is no non-peripheral washout. According to LIRADS, you should have a non-peripheral washout to categorize it as LR5. Again, here, it's probably better not to, term it and just look at it and be sensible and probably come up and say, okay, this looks like HCC. So So this is what is LRM. So for those of you wondering what is LRM, it could be mixed lesion like a mixed cholangio. As you can see, arterial phase enhancement, you're seeing an arterial phase enhancement, but actually it's a rim enhancement. In HCCs, you see a non-rim peripheral enhancement. So there is a limitation here. So you have here you have it's a rim enhancement on the arterial phase, and you're seeing something like it fills in centrally. So this is more like a mixed cholangio HCC. So you call it LRM. So this is a tumor in vein, wherein you can see an occluded vein and you can have a restricted diffusion. So what do you do if you have LRTIV? We end up doing MR diffusion. On diffusion restriction, if there is a T2 hyperintensity, if somebody reports LRTIV, ask for MRI. Diffusion restriction, T2 weighted images, mild to moderate hyperintensity on a T2 is suggestive of more of HCCs. So this is, again, this is a HCC with a fat inside the nodule. Again, this may not enhance very well. Again, this is on the right side, you have a HCC with blood inside it. Again, there is a limitation there, because if you have blood inside the HCC, if you have fat inside HCC, that's a limitation of LIRADS again. So very quickly, last few slides on the treatment response. What do we do? What do we need to understand in treatment response? We need to understand these three terms, as I said, non-viable, equivocal, and viable categories. One important thing is sometimes we do SBRTs and TARE, and we end up doing CTs pretty soon, in less than 3 months. If a patient has a TARE, they come back, and then you end up doing, let's say, a CT scan in 2 months' time. What you see is something like this. 3 months, even a 3 months post-treatment TARE or radiotherapy can have something like an enhancement all around the lesion. And you may say the patient has not responded very well. So they end up having TAREs or something like that. I have seen this in our own institute at times. We end up doing pretty soon, and you will classify it as malignant lesion still present or LR viable. This is not LR viable, this is LR-TR equivocal, because you are doing it just within 3 months. So ideally you need to do, probably more than 3 months later is what makes sense in those lesions. So that is something that we all need to understand. I'll just skip this one. Post-ablation, again, LR, there is a limitation, because if you see something like this marginal enhancement, this is completely normal post-ablation. You will have this is not a viable tumor, this is just a reactive hyperemia. What is abnormal is if you have a nodular enhancement, that is what is considered as an LR5 or LR viable tumor. So this is a little bit about the treated observation. So the limitations of LIRADS. Have I got 2 minutes? Chairpersons, have I got? Yeah, okay. So the first limitation is that LR5 has got only modest sensitivity for HCC. So up to 30% of HCCs, they fall into categories other than LR5. So if you see something in the report, you don't see LR5, does that mean it is not HCC? Not really, because 30% of those can be non-LR5 but still be malignant. So just don't go by the radiologist's report. Please have a look. It could be anything. So we need to look at the other features as well, the ancillary features, which are very, very important. So there is a revised LIRAD system which is not yet published in 2024. This includes lesions less than 10 mm as well, which falls under the same category as a 20 mm lesion. So here you can actually see in this particular modification, an 8 mm observation and a 16 mm observation has been assigned the same probability of being HCC. So these guidelines keep changing. So that is the reason sometimes I think we need to correlate clinically, and we need to understand, look at the other ancillary features and take a call. This is again a malignancy. What do you do with hypovascular HCCs? Sometimes we see patients who are referred for TACE, but they look malignant. It doesn't look very nice on the CT scan. You have something like this. According to LIRADS, this is not LR5. This could be LR4 or LRM. This is a hypovascular HCC, wherein you just don't see the enhancement at all. So again, this is not LR5 according to LIRADS. Sometimes you see a lesion with multiple intratumoral feeders. You don't see complete enhancement, but there are intratumoral feeders. What do we need to do if you see intratumoral feeders? You don't classify it as LR5 here, again a limitation. We need to do a subtraction image. It's only on the subtraction image you will see some enhancement and lot of these arterial feeders, and this automatically falls under LR5. So these are all the, limitations of that. And finally, I just want to show the radiotherapy image and then finish it there. I think we already spoke about that. The radiotherapy changes, post-radiotherapy, is because of microvascular veno occlusion, chronic microhemorrhage, parenchymal fibrosis. These are all the things which are responsible for the changes post-radiotherapy, 3 months post-radiotherapy changes. So this is a tear image, pre-tear and post-tear. You may think the patient has not responded. Actually, the big lesion, it has responded. He developed a new lesion. That's a different thing altogether, but this is a good response. So in terms of the limitations, everything in the field of medicine, I suppose, is continuously evolving, and these systems are in place to standardize and ease our communication. But one should be aware of the limitations and probably apply common sense and clinically correlate for every single case. Thank you so much.